So I'm going to start because it is 5:30. I can see there are still people joining us, but as I said, welcome to everybody who is joining us for our cataract webinar. This is a joint presentation with GIRF, the Royal College of Ophthalmologists, and colleagues from NHS England in Improvement. I'm the national co-lead with Carrie McEwen for GIRF Ophthalmology, and it gives me great pleasure to say congratulations to now Dame Professor Carrie McEwen. Also, thank you to Neha, Sophie and Michelle, who are in the background from the GIRF team, who are running the webinar for us. As often is the case, we're recording the webinar, and in terms of Q&A, please put as many questions as you would like to in the Q&A as opposed to the chat function, the Q&A. Michelle's going to monitor that and we'll pick up Q&A at the end of the session. So we're just going to move all the way through all the talks. If you could keep your speakers on mute during the session, we'd be very grateful. Okay, if I could have the next slide, please. So this is just to show we've got, in terms of attendees, we've got people from across the UK, well, across the UK and across all different aspects of ophthalmology and eye care. And it's a pleasure to welcome everybody, and we'll share all of this information on the GIRF website afterwards. Next slide, please. So my task is to set the scene and why we think there's a need for change. So the numbers of patients waiting for care in ophthalmology has increased significantly. This graph shows all those patients on incomplete pathways, so that's outpatients and surgery. Can I have the next slide, please? And if you look at that, there is, in terms of regional variation, there is regional variation, but this is the same for all of us in terms of ever increasing waiting times and the need for us to think differently than perhaps we did pre-COVID. Next slide, please. And this shows the percentage of patients who are now waiting more than 52 weeks. It's now nearly 50,000. It's probably more than this because this is March data, and it's shown a significant increase as we've lived through COVID. Next slide, please. And similarly, there is variation across the regions in terms of that waiting time, but it's a problem for all of us. Next slide, please. Touch time in ophthalmology. So touch time utilisation is a good measure of how we utilise theatres, and what good would look like would be to be more than 85%. So that's 15% for turnaround time and so on, but 85% touch time. Pre-COVID, we were around 72%, so there's an opportunity, as I'm sure we would all agree, for improvement. We've crept back up post-COVID towards 72%, which I think is a huge tribute to everybody, bearing in mind all the IPC guidance we've had to follow, but obviously there's a further opportunity for improvement. Next slide, please. In terms of waiting times by specialties and regions, this isn't just a problem for ophthalmology, and within the GIRF programme we have 6 work streams with 29 pathways for areas where we felt there was a particular concern or where we were asked to look and to help and support the response to COVID. Next slide, please. Those of you who've heard us speak before will have seen this diagram. I picked this picture of an iceberg a long time ago now, showing that, in fact, although we are all very keen to look at RTT and patients, therefore, predominantly in ophthalmology waiting for surgery, actually for us, the bigger risk potentially is under the water, which is patients waiting for outpatient appointments. So we're talking about cataract today, but there will be further webinars looking at glaucoma and medical retina and potentially urgent care as well. So if I could have the next slide, please. Ophthalmology, we're in a very fortunate position because we've got a moment in the sun or under the spotlight, depending on which way you want to look at it. Can I have the next slide, please? So in the national planning letter, eye care is mentioned specifically as a priority for 21-22. So now is our golden moment to really move our care of our patients with eye conditions forward. Next slide, please. However, there's some areas that are very specific in terms of what we're being asked to do. And if you look at in particular, the areas circled at the top and the bottom, looking at areas of high impact in terms of elective service models. And at the bottom, you can see that we're talking about ensuring that we have integrated care pathways across cataract, glaucoma, medical retina and urgent care. And by integration, that means in primary care, the community, and in secondary care. This is absolutely a team effort. And with ophthalmology, there's always a risk when you talk about cataracts. We all sort of starts very specifically talking about the numbers of cases on a list, which is not at all what we want to emphasize, although that is important. Next slide, please. So we developed the high volume, low complexity pathways just around the time of the first wave in May of last year for the 6 specialties as I've described. Ophthalmology was front and centre of that work, and we were asked to look at the cataract pathway. Next slide, please. This work has full support from regional directors and regional medical directors, so from an operational perspective and a clinical perspective, and everyone has signed up to the numbers of cases on the list, and that requires a whole pathway change. We recognise that there's independent sector input where required, but Declan is going to talk about how that can be tied in with training, because that's always been an issue in the past. For every organisation, and now I work in East Kent in a multi-specialty hospital, so each chief executive in all acute providers is asked to champion this work. And we're having clinical leads per specialty, per system and per region. And Manju Patel is here to talk to us, but is our Southeast region lead for ophthalmology. Have the next slide, please. So these are the pathways that we looked at, as I've said, and for us in ophthalmology, there's never been a better opportunity to influence, to change and to make things better for our patients and to support our colleagues in providing the best possible care for them. So if you ever needed a lever for change, we've definitely got it now. Next slide, please. I'd like to hand over to Carrie, who's going to talk about the specifics of the cataract pathway. Thank you, Carrie.
Thanks, Alison, for that introduction. And we're now going to be just talking about the title of the webinar, effectively, which is about cataract. Neha, could we go to the next slide, please? So why are we needing to consider making change for cataracts and try and improve their throughput? Well, apart from the fact that it's the commonest operation carried out worldwide and nationally, there's a huge variation within the delivery of the service within the UK. And these graphs both come from the GIRFT report, and they demonstrate on the left-hand side, for people who can't see the small detail, that the conversion rate of cataracts, that's the number of patients who are referred up for cataract surgery who then proceed to cataract surgery. And you can see therefore that graph is very, very variable, varying from about 20% of patients going forward for surgery to 95% going for surgery. And that reflects the fact that there's different ways of referring patients, there's different skills that are used, a whole lot of different things that need to be changed. The average is 70 odd percent, 71, 72%. And if you're doing 400,000 cataracts a year, I know that they're not all first eyes. That's a lot of wasted appointments for people who don't need an operation. And we recognise that 100% is no use either, because that means a lot of people get cataract surgery they don't need. But there is a happy medium. So that's looking at the conversion rate. And if we look on the right hand side, the graph there is demonstrating the number of cases carried out on a cataract standard 3.5 to 4 hour cataract list, and that varies from 4 to 12. So again, the average is 7, when since 2000 Action in Cataracts demonstrated it should be at least 1 every half hour. And that's not due to surgical inability, that is due to a whole variety of factors that could do with being standardised in the way we deliver cataract surgery. So we go to the next slide, please. So in order to look at some of this, and with the urgency that came around the post-COVID issue of huge numbers of patients that we've already seen waiting for prolonged periods of time for cataract surgery, it was agreed that one of the options, which is maybe is short-term certainly and may well be long-term, is to set up cataract hubs with high-flow cataract surgery, so that patients can be assessed for risk before they're admitted for surgery and can follow a very specific pathway. And the guidance on the right-hand side there is Royal College of Ophthalmologists and Getting It Right First Time have developed quite specific guidance on how cataract hubs can be set up and how we can get better access to high flow cataract surgery. So if we go to the next slide, please. So part of that has been this this end-to-end pathway of a patient from the very beginning of when they go to their optometrist or their own GP initially for cataract, saying that they're not seeing so well, or thought to have cataract, and this pathway follows them from the very beginning of that first appointment all the way through assessment, surgery, discharge, and so on and so forth. So this is a full pathway that has been agreed by all the people we see at the top. That's the college, GIRFT and NHS. And if we go to the next slide, please, I'm just going to show you what it's like. I'm not going to show you every actual aspect of this, but we've broken it down into very clear steps so that people can identify whether a patient falls into that category or not, what happens to them if the answer is yes or the answer is no. And then what we're asking is that each unit works to ask the question, are we doing that? Where does our practice vary? Is it, if it's different, is it better for our patients? That's fine, that's not a problem. If there's anything that we think that we could do better based on this or other information, and what might be the local blockers, challenges, or opportunities generated by this pathway, and then what are the local remedies to the blockers and challenges that we can pursue. So what it is sort of an outline plan that means that that every unit can look at it and see how it applies to them, where they could do better or where they could implement what there is. And the important thing round about it is that there are data collected for each of these steps along the pathway. For instance, on this particular limb, we've got percentage of patients given a shared decision-making aid before they come to the hospital, and patients seen within 4 weeks of referral to the hub. So that's two of the data collection points that we've got here. If we go to the next slide, please. And the next aspect of this, exactly the same questions being asked. This is once a patient's been listed for surgery, how they come through the surgical theatre programme. And what I really want to draw out from this is that action point number 1 there at the bottom says all this can be training lists, and that's key to what we're doing. High flow surgery is only suitable for trainees who are capable of carrying out standard surgery within about a 20-minute period. They need to learn how to carry out high volume surgical lists and how to conduct them. But on the other hand, it's expected that the other trainees can go and observe, but they need to be trained properly in surgery, both from a combination of virtual learning and from learning within the hospital that they work in, which is lower volume. That's well recognised. But training is a key part of this. Go to the next slide, please. And one of the other issues, again, just coming to the end of the pathway, is that there's a statement from the Royal College of Ophthalmologists and the College of Optometrists last week to indicate that patients do not require to return to hospital. We've got high risk patients with glaucoma, medical retina and other neurological conditions and so on, who must be seen by hospital staff, whereas this was reviewing a post-operative cataract, uncomplicated, is within the remit and the core skills of a standard optometrist. So if we go to the next slide, please. So we have a group of what we call GIRFT gateway metrics, and we have them for cataract, medical retina, acute ophthalmology, glaucoma and so on. But these are the ones that are standing up for cataract at the moment. And these have to be filled in currently quarterly in order to identify where any unit and system is with their ability to deliver cataract surgery, and how that changes over a period of time with the implications that we've already mentioned and support given, so that people don't feel that they are unable for any reason to reach the pathway or the equivalent pathway for their region in order to make sure that the optimum number of patients undergo surgery. Could we go to the next slide, please? So as mentioned earlier, there are opportunities for change, and within that, one of the things that I thought is that 20% reduction in patients not suitable for surgery is achievable, and also that 85% of all cataract surgery is suitable for follow-up in the community. So these are things that we've been told through discussion that might well be possible. Go to the next slide, please. One of the things that's important about this whole programme is that, as you possibly be aware, there have been a number of programmes around elective care, national outpatient transformation, GIRFT, national eye recovery and transformation. There's been any number of different things, but this is tying up all of them together so that there is no dubiety about who is doing what, and there's only one visit to each unit. And basically what we've got is divided into, we've got all the targets for all the different programs that previously existed, and we have divided them into pre-hospital, hospital and post-hospital actions that we might be able to gain some more ability to see more patients. We'll go to the next slide, please. All this information is available on the best practice library in GIRFT, and you're going to hear a little bit more shortly at the end of this presentation from Mary about the information that's available for everybody on the Ophthalmology Eye Care Hub. We go to the next slide, please. So the important things that trying to work here is that we've got gateway metrics and meetings and regional meetings, system meetings and unit meetings where required. And there's been systems with leadership and full collaboration set across the region and systems. Every region has, well, bar one or two at the moment, every region's got a lead ophthalmologist and a lead team round about that. And what we're trying to do is work locally to make sure that these are not just ideas, these are not just pieces of paper or information on a website, that there's actually going to be genuine buy-in from everybody involved within the system. And that means looking at everything. It means looking at the way appointments are made, it means looking at the space that's available, it means looking at workforce planning, and it means looking at commissioning and contracting. So there's a whole lot of things that are being added up together. It's not just some ideas and this is to get on with it. The whole thing has been wrapped around by a large programme. We could go to the next slide, please. So the question always is, and this is Tim Briggs here, who asked the question, who wants change? And the answer is everybody. But the question is who wants to change? And I think we all recognise that is much more difficult, and it's something that we need to very carefully consider and make sure that everybody in a unit is in the same boat. So at that point, I'm going to hand over to Manju, who will introduce herself and the topic she's going to be discussing. Thank you very much.
Hi, thank you, Carrie. My name is Manju Chandran. I'm one of the consultant ophthalmologists working at Frimley Park Hospital. And I'm going to talk to you how we are in the process of setting up a cataract surgery hub at Frimley. Next slide, please. So Frimley Eye Treatment Center caters to a population of around 400,000. We borders between Hampshire, Surrey, and Berkshire. And we perform around 5,000 cataract surgeries every year. Like anybody else, we also had challenges due to COVID, backlog issues, capacity problems, and of course, patient restrictions. Next slide. So just a bit of a background to my story. And I took up the clinical lead position at Frimley on 1st of October 2020. The same week itself, I was also given an additional ICS lead role and was asked to attend the NHS E&I Theatres Adopt and Adapt workshop. Like as everybody knows, the main focus was on the establishment of surgical hubs to reduce the 52 weeks waiting position. In the meantime, Frimley was in the process of setting up a new hospital at Heathermoot, which is around 6 miles off from Frimley for all the surgical specialties. The main focus was on all the big wigs in the trust, namely orthopedics, general surgery, urology, and ophthalmology was not of any concern at all. As part of a clinical lead role, I also got a copy of the email saying that if you want to secure a footprint there, this is your last chance, submit a proper business case. From all the enthusiasm I received from the NHS E&I GovT meeting, I discussed with my colleagues and wrote out a business case explaining all the pros and cons about setting the hub. Next slide, please. My approach was quite simple, basically understanding the need, defining the future, built a business case, leadership approval, and finally implementation. Next slide. So the first part of the business case, it has got plan A and plan B. Plan A was to do high volume cataract surgeries, 20 per day, 100 per week. Plan B, I threw some amount of innovation into it. I said we can even consider doing completely a one-stop cataract surgery hub where we see patients and operate on the same day, taking all the waiting lists out of the equation. However, due to the COVID restrictions, and this Heatherwood Hospital is completely a green pathway, the second part of the plan did not go forward. Next slide. And it was very easy for me to fill in this Frimley Cataract Surgery Hub pathways because it was basically the recipe that was given over by GovT, electronic referrals, one-stop patient assessment and pre-assessment, weekly 100 cases. And at Frimley, we already had been practicing home dilation and bilateral surgery, and we will be replicating the same at Heatherwood. And it's all a part of a green pathway. Next slide. This is how a one-stop cataract assessment clinic works at Frimley, where we vision them. Biometry is done before dilating. Then we have an OCT as part of the equation, which I know most of the trusts in the region doesn't do it. And followed by that, the doctor assessment, and then pre-assessment by the nurse consenting, and the patient is sent home with the drops for home dilation. Next slide. On the day of surgery, staggered arrival times, patient attends the hospital 30 minutes prior to surgery. Everybody arrives with dilated pupils, confirmation of consent and site marking by the doctor/nurse. There is a dedicated eye care pathway for admission and discharge, and we are planning for the whole patient journey to be over in an hour's time. Next slide. So as part of the business case, that meeting I attended on that day was so helpful because I got a couple of slides regarding the ophthalmology waiting list in the region. So I incorporated a couple of slides from there as part of the business case submission. Next slide. Next slide, please. Of course, we have to include the financial projections. Since my time limit was quite small, I had a chat with the finance man in the hospital, and he gave me rough figures for my plan A and plan B. He said submit both and then see how it works out. First, I put the column for the income, followed by the costs, including the staff costs, equipment, and consumables, and put all the numbers on board. Next slide. So after writing up this business case as a part of an email, nobody gave me any sort of follow-up or anything. So I thought it was going to be in the dustbin. I thought, let me take it forward. I talked to my colleagues, clinical director and the operational manager, who really supported me, set up a meeting with the CEO at Frimley. And fortunately, he used to work with Berkshire before and was quite aware of the mass surgeries at Buckinghamshire, and he perfectly understood the situation. I presented the business case to him and with all the details for the waiting list in the Southeast. He asked me to meet the chief operating officer who is in charge of Heatherwood. And he said, I will give you a place for you to present your business case and you can compete with all the other specialties. Of course, the main specialties they were focusing were orthopedics and vascular, urology, max facs. Ophthalmology was at the bottom of the pile. And next slide, please. After submitting the application and presenting the business case, the results was announced quite dramatically after 4 weeks. Everybody thought orthopedics and general surgery was going to get all the theaters, but ophthalmology was given a dedicated eye cataract surgery theater and 2 clinic rooms for assessment. One of my operational managers said, "You ran the Grand National, you started at the back of the queue, but you finished first." And thanks to GIRFT and that workshop I attended because of the innovative idea I had. Next slide. So retrospectively, what worked well for me? On the base of background of this National Eye Care Transformation Plan, I had a clear business justification. It was an innovative approach. And of course, it had the financial projections. Next slide. Presenting the business case and getting the approval was very easy, but I know I have got a long journey to go. The hospital is opening only early next year. I have to engage with the optoms in the community, refining the referral process and integrating them in the pathway. We all talk about collaborative working. So we have also entered into collaborative working with Bausch & Lomb as part of a managed service contract where they will look at the leasing of the equipment and also the associated service costs. To make the offer more attractive, we have put some private work also on the table. So for people locally in the area can come and do private work in this place, which might be open during the weekends. Next slide. So I know that COVID has given us new ways of working, new ways of thinking, and it's a long way ahead. And like Henry Ford said, coming together is a beginning, keeping together is progress, and working together is success. I know it's hard work, but we have a long way to go forward. Thank you. So the next talk is by the role of training and college by the Royal College President himself, Bernie Chang.
Hi, everyone. So the next few presentations actually will be focusing on training. And next slide, please. Next slide, please. Yeah, so I'm a consultant ophthalmologist based in Leeds, and I do wear 2 hats in that I have a substantive NHS post, but I also work in the private sector. And because the audience out there may not just be ophthalmologists, so the college essentially does things for the benefit of patients and the profession of ophthalmology and those who deliver eye care. And our mission is to ensure that everybody achieves or is able to receive the highest quality care through excellence in training, education, and assessments of eye surgeons, and to uphold standards and promote research and innovation. Next slide. So in terms of training, I believe the college has an integral role. So we develop and review the curriculum for ophthalmologists, and we conduct the examinations. We also provide some of the training, such as microsurgical skills, and provide education, CPD, and training for supervisors and trainers. We also hear and have input into this from the ophthalmologist and training group, and you'll hear from Sunil, their chair, a bit later on. And we provide advice on education and training issues and offer the e-portfolio for trainees to use. Next slide. So we don't do this on our own. We collaborate with the statutory education bodies, with the GMC, with local deaneries, schools, and trusts, and the GMC, of course. Next slide. So in terms of specialist training, after your foundation training, doctors can enter via national recruitment into a 7-year program where they will then come up with completion of training. And there are other routes that you can enter specialist training, so you don't have to necessarily be appointed at national recruitment, but on the main, majority do come in through national recruitment. Next slide. The staff and associate specialist grade, the specialty doctors are highly important for the workforce, and they also have opportunities to become consultants through what we call the CSER, the Certificate for Eligibility for Specialist Registration. And quite recently, our college was involved in the development of the new SAS contract, which hopefully will attract more into that grade. Next slide. So we are also involved with training nurses, optometrists, and allied health professionals. And we work closely with the different other organizations to develop the ophthalmic practitioner training curriculum in order to offer different levels of training up to the master's level or level 3, where it's expected that they will be able to practice independently within the appropriate setting. Next slide. So in terms of capacity, if you look at the ophthalmology workforce, we are 0.03% of the consultants in the NHS. And yet we see about 10% of all our patients, and we do at least 6% of all the surgeries in the NHS. So clearly we do punch above our weight, and we've only been able to do this by working as a team with the various professions mentioned earlier. Next slide. It's definitely going to be a challenge for eye care professionals to balance service and training. We're talking today about how we deliver high volume cataract. There's high volume diagnostic centers being set up. We're using more remote methods, virtual appointments, and delivering more care in the community. And we know training needs hands-on experience. And COVID really has, in a sense, made things a lot more difficult. Next slide. Very early on during COVID, trainees were redeployed, and 74% of ophthalmologists in training had no exposure to ophthalmology at all. So they were either running wards or perhaps helping out in ICU. Next slide. And in terms of the area where our trainees were most concerned, not surprisingly, cataract surgery opportunity was what they were most worried about. Next slide. And even in August of last year, quite a lot of trainees felt they couldn't complete their training objectives, and 47% of them had one of their exams cancelled or postponed. Next slide. A lot of trainees, 41%, felt that there was going to be a delay in completing their training. Next slide. So who's most affected? Well, not surprisingly, the more junior you were, the less opportunity you were going to have to get hands-on cataract surgery. And if you were working less than full time or shielding, academic trainees and trainees with caring responsibilities are the ones who are going to be hardest hit. Next slide. So as a college, we do recognize that particularly in ophthalmology, the independent sector, any qualified providers were doing more and more cataract work. And so one of the things highlighted in this work stream from HEE is that access to private sector lists were going to be very important. Next slide. So we were quite lucky. We were able to get into discussions with HEE and the independent sector to try to develop guidance for placement for doctors to work in the independent sector. And that is gathering pace. Next slide. So to us, it doesn't really matter where training is delivered, provided the standard of training and the experience that the trainees get is equal or better in the independent sector. Next slide. So over the gist of it, training is imperative. Without training, we're not going to get the next batch of consultants who are able to do high volume cataract surgery. And it is going to be challenging. The balance between service and training will be severely tested over the next few years. But I think we've got to be creative, and we have to use all opportunities to train. And that includes using the independent sector and training in high volume centers, which hopefully we'll hear a bit about later on. Thank you very much.
Hi there, and thank you very much for the opportunity and invitation to speak on this webinar on behalf of the Ophthalmologist in Training Group. My name is Sunil Mantor, and I'm the chair of that group. Is it okay to go to the next slide? Thank you. So, essentially, we're going to be talking about what's the problem with regards to cataract surgery training from the trainee's perspective. And it's very, very easy to blame all of this on COVID, but I think it's also important to take some reflection and think about how have these problems been evolving over the actual past 2 or 3 years? Because as a committee, we're responsible for representing trainees all over the country. And over the last few years, we have had complaints from trainees that they feel that their cataract surgery training, particularly for the more junior trainees, has been affected. And we think this is really because over the last few years, as we know, there's been a developing backlog for cataract surgeries, which in part is why the independent sector and AQPs have evolved and taken such a leading role in the delivery of cataract surgery in our country. But because in some parts, management and hospitals are really prioritizing and getting as many cases as done as possible, that has led to a balance being made with training. And what I really want to emphasize today is it's not really about the numbers. I think it's all about efficiency, making a plan, learning from areas of best practice, and making the most of the opportunities that we can give to trainees as well. So, as we say on the slide, what's the problem? I think it's theatre availability. In some regions in the country, ophthalmology theatres have been converted almost permanently to providing care for non-ophthalmology patients. Lists are therefore a problem. And because we haven't been able to list patients during COVID, we are in a situation where across the country, there are many lists which are just underfilled or even not booked at all. Simulation's been amazing during COVID, but as Bernie's just said there, it only takes us so far. And we really need to give hands-on experience to our trainees, especially the most junior ones. Is it okay to go to the next slide? With regards to the recovery from COVID, I think it's highlighted issues that are not just applicable to COVID. Trainees coming back from maternity leave, paternity leave, extended breaks from the training if they've had out-of-program research. These are difficult times. And when we've come back from COVID and we've been resuming our training and our surgical training, it really has highlighted the importance of giving some TLC simulation opportunities and training and some extra time for trainees, not just trainees, though, but even consultants who have often returned to surgery from breaks up to as long as 6 months or even more. So that's been a real reflection from the pandemic, I feel, which I really do hope that will go into the long term in terms of also how we empathize and give a bit of support to trainees who are coming from extended times. And I think we also need to think about theatre downtime. In COVID, sometimes we've only had 3 or 4 cases on a list, and that's been because of PPE needs or social distancing requirements. But I think some units and departments across the country have really struggled to ramp up the numbers of cases across the country just because of difficulties with logistics there. Is it okay to go to the next slide as well? So I think going forward, there's multiple things that need to be done, and there's no one single best fit answer. I think it's been really clear that there's been a really huge disparity across the country as to how trainees have been affected, either because of COVID or because of departmental strains. And I think we really need to give some personalized care, which I think HEE has given some advice about and the college has given advice about, which is looking at those trainees and seeing who has had loads of lists, who's managed to do loads of VACOs, maybe giving some of those resources to some of the trainees who haven't managed to have all those resources and training opportunities while they've been either redeployed or not able to access theatre in a unit where they've had a difficulty with restarting and resuming theatre. I think we also need to really reflect and consider how we maximise the theatre opportunity. If cases are not booked, then maybe we should have and encourage trainees to be doing some simulation training on Model Eyes with their consultants, or working with the management and making sure that the trainees are in lists where there are as many cases booked as possible. And I think that doesn't mean just booking as many cases as possible. I think it's all about optimizing workflow and work streams. And we're going to hear, I think, in the next talk from Sarah Mailing, who has really revolutionized some training opportunities in Oxford. And from my experience of talking to trainees across the country, it's really clear that even in neighboring regions or even neighboring hospitals, 2 hospitals 10 miles apart from each other, they're doing completely different things. And I think it's really important to have these webinars where we can share areas of best practice and take them back to our own hospitals and really challenge our teams and our managers, especially, and say to them, why can't we do what other departments are doing? Of course, the independent sector is taking a significant chunk of those routine cases and cataract surgery in recent years. And the college is doing some amazing work with engaging with the independent sector to fight for trainees to be able to access some of those cases as well. Okay, to go to the next slide. So I think that's it. And thank you for the opportunity. I'll hand over to Sarah Mailing now.
Good evening, everybody. It's lovely to be here and a privilege to talk to you about something I'm passionate about, which is both training and patient care. So I've been privileged to be involved with Mike Adams and Buckinghamshire Healthcare Trust since 2019. We set up our first hub high flow cataract unit. And next slide, please. And what I'd really like to share with you today is maybe some little tricks into how we can really put training front and centre of this COVID recovery plan that I'm sure all of us are going to embrace. This slide really just shows a lot of what you've already heard, which is a pathway that you can see down the side, which Carrie so eloquently talked us through, that we now use for our cataract pathway. And really, it just showed that right at the start, we wanted our hubs to be GIRFT compliant, compatible with training. And that's something we've tried to make happen the whole way through. Next slide, please. So really, when we think about training, we think why, what, and how. So why are we wanting to make sure it's front and central? Because we've been really told that that's the way that we're going to keep making sure that people can operate safely on all our patients and ourselves in the future. And we've got a new curriculum coming in, which is really going to define cataract surgery as a subspecialty skill in its own. And that means that our trainees are going to need to have a really personalised, as Sunil has mentioned, pathway through their cataract training. And we as trainers should be embracing this and enjoying that opportunity to teach in a way that perhaps we've always wanted to teach in, but recently haven't been able to. We're going to use a spiral curriculum. We always have. You start at the beginning, you embed it in from ST1, and then your expectation is you're going to be an 8-case normal cataract on a list surgeon. So our expectations have changed. We're no longer in the situation where our regular lists, which are appropriately scored and appropriately planned, are going to be 4 or 5. A regular list will be 8. It'll be normal to do 10. And on very specific training lists, you may choose to have smaller numbers. But that definition of cataract surgery moving forward is going to be something that we're excited to change. And I really think underlying all of this is a cultural change. Our trainees expect us to change. We expect them to do more cases than we were expected to do. We didn't talk about doing 12 on the list when I started in cataract surgery. You just talked about getting through 1 and hoping you'd get to 2. But now our trainees, and certainly our ST4s and 5s, are really getting through 8+ on the list. And really that's something we need to get from the start, and we need to give our trainees the opportunity to make this a possibility. Next slide, please. So we know that at the moment you have to do 50 cases by ST3, 350 cases to CCT, and if you compare that to the United States, they do 86. So we know that we already do a reasonable, or we think reasonable, number in our training time, but we also know from papers that Fiona Spencer produced in Manchester that actually there is a reduction in the cataract numbers per list and reduced opportunity before COVID. So I'd just like to underline what Suno was mentioning, and that is COVID may have highlighted these problems, but these are certainly not problems that were not there before. We really do need to redesign the delivery of this from the start. And if you redesign the delivery, we've, I think, been able to show that the increase in opportunity, again, as mentioned before, not just locally, but regionally, for all trainees to have access to cataract surgery is something that we can put on the table. Next slide, please. Okay, so the redesign really involves leadership, and I think that's been mentioned by everybody. I didn't have a cataract lead in the departments that I trained in early days, but we found that if 2 of us, we can barely keep up with what we have to do. So I think there needs to be a consultant leader too. And I think by having somebody or working together, you'll find that you'll be able to work through what really is an entire quagmire of difficulty to get from your one-stop pathway, certainly from referral into one-stop into flows. And by the time you add in pharmacy and CCSD, you'll realize that you need more than one of you to answer the midnight emails. There obviously needs to be a departmental change. There needs to be collaborative work, there needs to be understanding and a passion to change. And we've been really fortunate that not only in our Cataract Hub, which is an independent theatre suite, but also we ran a cataract-a-thon in our eye lists to show that we can actually show the same changes that we've been able to do in a different setting within the confines of our hospital eye theatres. And so I think departmental change that you can start from externally and bring in shows that it really has taken root. And I think you need to put training front and center of all of this. Okay, next slide, please. So when we think of lists and when you think about training, you need to think about all lists starting with an 8. And really you're going down to specifics. Now those numbers are annoying, but it involves in scoring of your lists. So for instance, you'll have 2 cases over a 5, 2 cases which are 3 to 5, and 4 are less than a 3. So you'll have a mix on the list to allow you to train. If you're doing the high volume lists, which are 10 to 11, and we're not talking about Jack and Jill style where you've got 2 theatres running side by side, you need to know that your flow and actually your downtime is the problem. As it's been mentioned before, it's seldom the surgical time that is difficult. It is usually the flow and turnover of patients through theatre. And so if you're going to increase your numbers, probably the last person you need to talk to is your surgeon. And probably the first thing you need to do is deal with your flow. Then you add in your trainees. And depending on what trainee you have with you, you will then adapt the list, not by numbers, but by what they do, depending on what's coming through the door. Next slide, please. So if we just look at what we've managed to do during COVID, between February and July of 2020, I mean, these are difficult slides, but the outlier, which is Stoke, which is blue in the bottom left, shows you that 100 wasn't unusual. And certainly our more senior trainees were getting up to 100 cases during this time. So we obviously still face the difficulties of COVID. We were certainly blessed with an opportunity to operate, but it does show that our recovery plan really did include our trainees from the beginning through to the end. Next slide, please. Obviously, you need to keep simulation going through, and you need to video review all the way through training. You need to preoperatively plan and score appropriately, and you need to surgically plan all your patients. But it has now been shown, I think, quite clearly in the literature that with one-step training of new trainees on a list, you'll get 8 steps, for instance, with an ST1 and a high flow list, which not only actually increases their number of minutes on the eye, but it's been shown that it reduces the complications and gets them through the full cases faster. So at our cataract theatre, we did the eye efficiency equivalent and showed that if in an under 20-minute operation with a 4-minute turnaround, you can easily give a trainee 6 minutes on every single patient. Next slide, please. So opportunity, when a trainee can do 4 in a case in our trust, in 2 hours, they're ready for an 8-case list. And what we found, and again, to just cement what's been said already, is that if you provide a service where you are performing high volume cataract surgery, you are also providing a service to the region because your regional trainees should have access to these lists. Next slide, please. So this is my summary of how to train in high cataract hubs. So there needs to be a culture change. There needs to be an expectation that's embedded both with the trainees and the trainers. And there needs to be an opportunities for getting to these lists needs to be expanded. And I think everything that's been said before really shows what we should be doing. And all we want to say from Buckinghamshire is that we've tried and we feel that we are succeeding. And therefore, if we can all learn from each other, I'm sure we will be able to move forward and ensure that our trainees quickly feel that they're back to where they were before, and in fact are accelerating to levels that are far beyond where we are. And I can't wait till I'm leaving at the other end of my career and somebody's telling me that the 50 on a list that they're doing is actually a walk in the park. Many thanks. We're moving on to Declan now, who's going to give us the view from HEE.
Thank you, Sarah, for that introduction. It's nice to see that there's a very positive feel to this meeting with the presentations from Frimley Park and Stoke Mandeville demonstrating that if you're prepared to put in the effort and grind through the detail, you can deliver training and high volume safely. My slide is more mundane. Next slide, please. My brief was to talk about health education England's perspective on this, starting with money. Education has a budget of over 5 million, which has increased significantly this year. It's sad to remember that almost 50% of it goes on postgraduate medical and dental training, 22% goes on undergraduates, and only 20% goes on non-medical and multi-professional. And it's sobering to remember there are far more non-medical and multi-professionals in this business than there are doctors and dentists. But that's the way it is. Next, please. Health education for ophthalmology. There's a recognition. The role of HEE in cataract surgery is to make sure that there are enough trained doctors and others to do the cataract surgery safely in a sustainable way. HEE funds this. It runs the recruitment. It funds the schools which run the training programs, support trainees in difficulties, and runs the ARCPs. And this is a complex arrangement with the colleges, which is historical. And finally, it's all quality assured by the regional postgraduate deans, the lead dean for ophthalmology. It's important to keep those two last slides in perspective. Moving on, please. Shona McLeod, the Deputy Medical Director of HEE, only 2 weeks ago said, we must unite training and service recovery. HEE recognises that its role, that the practices associated with high volume, low complexity working are the only way to meet the demand for cataract surgery, which our population rightly expects us to deal with. They're here to stay. HEE is very keen that these areas are used for training. Bear in mind that high volume, low complexity units are likely to be the workplace for many of our future trainees and AHP, so they need to start working there and training there. As Sarah implied, to train safely in these places, you need planning, and the planning is not so much about numbers, but as to what trainees actually do and have an objective for them. HEE is keen to minimise training extensions as they feel they don't add much value. HEE has given Trust 12 million to support training, which was gone to all trusts. It's a paltry amount, but if your eye department doesn't ask for it, you won't get it. So I would go chasing it with your Director of Medical Education. And finally, and most importantly, commissioning contracts must facilitate and not disrupt training. HEE and NHS England have been completely clear on this. Commissions have a huge role. They cannot just concentrate on the 2 million or 3 million backlog. They do have to look at training. Next, please. So the role of HEE is to maintain and build an NHS cataract workforce, which is multidisciplinary and able to cope with the growth of 2 to 3% a year, because that's the rate it's growing at. And that's about what Stoke Mandeville, I think, was predicting. It's got to be multidisciplinary. There's a recognition from HEE that they favour the development of advanced care practitioners across medicine. That's a recognition that there will never be enough doctors to meet demand, and arguably you don't need the highly trained 15-year doctor programs to produce competent advanced care practitioners. HEE is now funding MSc training for allied health professionals in ophthalmology. This is a new and major change. They're putting money into senior nurses, senior optometrists, and senior orthoptists in the way they have been putting money into ophthalmologists for years. So we need to capitalize on this. Next, please. Health Education recognises that there's a need for at least 500,000 NHS-funded cataract procedures a year. As Bernie implied, at least 30% of this work is currently done by the independent sector. It's risen from 18% 3 or 4 years ago, and it may well be near 40% now. The independent sector, as a method of doing large numbers of cataracts, is here to stay. And frankly, that's exactly the same as every other developed country. No other developed country has attempted for years to directly run all cataract surgery. They have outsourced it to highly regulated, competent institutions. Bear in mind too that it's the same workforce in the independent sector as in the NHS trusts. The same doctors and nurses, and there's not enough of them. It's recognised that IS cataract provision is essential for the health economy. There is wide variation in how often they're used. As in Stoke Mandeville, I think the use of independent sectors is minimal, whereas I think 20 miles down the road, the situation is totally different. There is no doubt that some parts of the country would get a very bad service if it wasn't for the independent sector, and some large trusts do incorporate them into their planning and work with them. All providers of NHS funded care and ICSs have a responsibility to facilitate training, and Health Education is very firm on this. They're also insistent the IS cannot rely on the NHS and HE doing all the medical workforce training as we used to do. Next, please. As Bernie implied, this has been the subject of extensive and slow-moving discussions to get trainees into the independent sector. We need to avail of all opportunities for training. Commissioners need to facilitate it when necessary. Bear in mind, the Health Education and the NHS tariff will continue to cover the trainee's salary. The salary will not be the responsibility of the independent sector. The HVLC operating model ensures that 8+ cases can still be done on training lists with trusts and in the IS, and that should reassure the independent sector that they will still be able to have a viable business model even if they have trainees regularly. And they must have trainees regularly. They can't have them just now and again. The clinical and education supervisors for these trainees will still come from the NHS trusts, preferably the same trusts who know the trainees, but that's not absolutely essential. IS training sites need GMC approval, which is easy to get. And finally, and not least, trainees must be involved in planning IST training and in feedback. So if it's not working, the trainees need to say so. Bear in mind, it is their careers that we are playing with at the moment. Next, please. In the indemnity, staff, NHS staff in the training grades who work in independent hospitals as part of NHS training are covered by NHS indemnity, the Clinical Indemnity Scheme for Trust. That has been specifically spelled out by HEE and NHS resolution, or is it NHS retribution? NHS resolution. Provided they work, that such work is covered by the NHS contract and provided the trainees under supervision. Just like, strictly speaking, in NHS trusts. The independent sector is covered for this, that's been clearly stated. Next, please. And in summary, Health Education England recognises they have a responsibility as far as they can to ensure that there is a workforce fit to train, fit to perform 500,000 cataracts a year. They recognise that the practices developed by GERF and others in high volume, low quality sectors are essential to meet this demand. All providers of NHS funded care have a responsibility to facilitate training, and that includes the integrated care centres. The IS cap provision is now essential and is essential for the economy. The IS cannot rely on the NHS and HE doing all their work for them anymore. And finally, and most least, we're not going to get any real change unless commissioning contracts facilitate training and reward efficient, effective practice. So that's a quick run through HEE and 5 billion a year. Thank you. The next slide, the next talk is by Mary Lineage she's from GERF, and she's working the support and collaboration role. Mary, over to you.
Thank you, Declan. Just to clarify, I'm part of the National Eye Care Recovery and Transformation Programme with NHS E&I, but work in collaboration with GERF and NOTP programmes of work as well. Thank you. Next slide, please. Lovely. Today, or should I say this evening now, we're going to cover 2 areas that we've been doing within the programme, which is just sharing with you the support offer package that we're sharing to our regions and also our integrated care systems. I'm mindful this is probably things that are kind of towards them, but actually it's your awareness that this is out in the system, and it's for yourselves to be working, you know, in the collaborative way with our systems and our regions on how do we ensure that we're enabling the eye care recovery and transformation across England. Next slide, please. So we're going to cover the support offer, and this is just like the content that's within this document. And in there is really two key areas, which is really the universal support offer. And what does that mean? So that's access to expertise, training and upskilling, and some skills and such like. So actually picking up on some of the items that have probably been discussed earlier. The second element that we do contain is the universal eye care pathways, and that's covering those key subspecialties that we've got there, and also we'll be providing as and when it's been developed through the commissioning support as well and guidance. Next slide, please. So this is just a little bit more in-depth of some of the elements within the support offer. So it gives you a bit of flavour of what do we mean by some of these things in regards to access or the networking elements. And again, just clarifying, there's the two levels there. And all of this information is been obviously sent through to the regions and the systems, but for everyone, it is accessible through the future eye care hub, which I'll cover in a moment, or you can contact us through our email address that's available, and I will share later on. Next slide, please. So moving on to the eye care hub. So the support offer that I've kind of went through quickly there is going to be available on there, and I'll show that through the demo that we'll do in a moment. But one of the key areas that we want to share with you is the eye care hub, which is a shared platform. And we want to really work with you and also all of our wider eye care stakeholders. So this hub now becomes a community of practice. So we start sharing our sort of documentations, our conversations, and create those forums of collaboration. So it's an environment to promote and also to kind of employ that co-design with your colleagues and to the wider eye care services. At the moment, we hold a huge resource of tools and some guidance and such like, and we'll be building on the sort of news and working with our stakeholders. So we're, you know, linking in with the colleges and our charities and obviously our other programs as well, and promoting that community of practice. Next slide, please. So just to give a flavour of like, well, why would people want to use this eye care hub? And these are like a couple of kind of examples of users, and we thought we'll put it in this context. So if I was an ICS and I wanted to understand, well, you know, what works is actually, you know, you can go there for some shared practice and actually open up some discussion forums and look at some case studies. And like today, we've got some excellent case studies that, you know, we've shared here, but actually we really want to share that out wider and kind of share our learnings as we've gone through that. And also as a national programme, if we've got some things that we want to share out, we'll use it as a platform to keep you all updated, whether that's through news items or events like these, and any other kinds of engagement that you think would be beneficial on the longer term. I'm not going to go through all of them, but that just gives you a bit of a flavour of why we want to use the eye care hub going forward. Okay, next slide, please. Okay, I'm now going to share my screen and we're going to just do a live demo, if that's okay, because that will give you an easier access to what it feels like using the platform. So just bear with me while I just share my screen. Okay, I'm hoping now you do see my screen. And so this is now the eye care hub that we've gone on to. At the moment, you do need to get access to it, but for next week, we are going to go on to open access. For those of you who have used future collaboration platforms previously, it's quite easy to log on and get membership through. And as soon as you're able to get on, we go on to the open one. You don't have to ask for a request permission onto this site. So as you can see on here at the moment, we've got the support offer that we just mentioned. and our how-to guides, which I'll go through in a moment. And we have our news, events and discussion forums, and a suite of other things, including primary care, because we feel that's the primary aspect of our programme, and also toolkits, which will hold our transformation elements as such. So if I just walk you through kind of an example. So I've just shown that support offer that was there. As you can see, as you scroll through here, if you were to go to say access to expertise, it just tells you what's available and how to access that information. If we were to go into the eye care pathway elements of it, so as we're talking about cataracts today, we'll go through the cataracts. And in here now houses the how-to guide, which we'll go on to in a moment, and also information that was, I think Harry shared earlier, of some of those recovery and transformation opportunities that are available too. So I'm going to go through the guide and just walk you through that now. So the guide now is on a web-based, obviously, platform, but you can download this as a PDF if you so wish. And in here houses the information that are key things that actually, you know, to enable that universal approach to providing cataract, it provides that information for you. Then it goes into actually if there are key things that need to happen and kind of a phase period, it just goes through them by phase. And also if we move on to how to implement certain things. So we've actually broken it down to pre-hospital and also to post-hospital as well. And it's just helped in the hospital elements, things that, you know, are useful before the day and on the day. And these hyperlinks will just take you on to the key information. So as this example, it gives you the information underneath it and it carries on giving you further support as you so wish. So as I walk through the rest of this information, we also house in here as well any other useful information. So our other stakeholders information that we feel is relevant. And also any of the case studies we do have to hand, and this is an area which we're building on and wish to be working with you all and to identify, you know, some excellent areas of work which we want to capture and share with your peers as well. And also, as mentioned earlier, we've got housed here those opportunities that I mentioned earlier too. So going back onto that main screen again, there's a suite of information available to you. What you do have as well is a discussion forum. So if you were to start a discussion that you're curious to understand or want to ask how people have done certain things, it's an open area. So it's not for us to start those things off. You can actually start a discussion thread in that way. And also in here as well, we'll be building and working with our charities on building some patient support information. So that will be useful. And our toolkit, which is still under design at the moment, is where we'll be holding all our digital transformation information and our new pilot that we'd like to share with you, that set of information, and also our commissioning workforce and our data as well. And these are areas that are going to be built up over and work with you of any information that you feel is would be useful to you all as well. And a useful little function, I'm not really that tech savvy, but I have found this quite useful. So we've got tags in here. So if you were to select cataract, it will bring up all the items relating to that subject matter. So that's my walkthrough. And what I will do is I'm now going to stop sharing. And I'll pass the baton back over to Alison and Carrie for Q&A.
Thank you very much, Mary. That was fantastic. So firstly, thank you to everybody, all our fabulous speakers. We've talked about the need for change and why we can't carry on as we are, what we all can do together, and given some really brilliant examples of work that people have been doing. Really focused on training, and I remember as a trainee never wanting to be done unto, so thank you, Sunil, for giving your perspective, and for Sarah to show what can be done to help and support trainees. And then finally to our colleague, to Mary, for talking us through the new eye care hub. Carrie, in terms of questions, I think that there was a summary of questions around training. Should we take those first?
Yes, we can do whatever. I think Bernie's answered a few of the questions around about training. Bernie, do you want to maybe just reiterate some of the answers that you've given around the importance of trainees, SAS doctors, and how we can get training within the independent sector?
Yeah, there was some questions about the whole training in the whole cataract pathway, and that's absolutely right. We're not just training surgeons to do the surgery, but to be able to manage the whole patient journey, and that's really important. And I think that's why it was important in the joint statement. We're not saying that every single patient should be discharged. We are aiming for about 80%, because that can really free up capacity in the hospital to see patients who are at higher risk of problems. But I think the needs of the trainees can also, we can be adaptable and flexible. If the hospital itself can't offer the cataract assessment, for example, there's no reason why trainees can't have a placement in the community where these things are taking place. And likewise, they can also see post-op patients there in order to complete their training. The thing about SAS doctors, we definitely recognize that the SAS doctors play a huge role and are very, very important. And we're not going to get more training numbers because we are, in a sense, cancer A&E is always going to win out when we ask for numbers. So the SAS group is where we can grow, we can get more consultants. So that's why we're developing the ophthalmic local training opportunities in order to facilitate CSER, getting the requirements for CSER.
Thanks, Bernie. I think, and then just Sarah and maybe Sunil, there's some reflections on sort of training and the environment if you're taking trainees through high volume lists in terms of how they might feel and pressurised or not. What's the feedback from your trainees, Sarah? Do they like it, or do they say run for the hills?
I read a couple of the comments, just a couple of things. I can't really emphasize how much we put the patients really at the front here. So I would be really disappointed if a patient felt that they hadn't had really exemplary care, and we have never had a complaint from our hub that they felt either rushed or on a conveyor belt. In fact, it's been quite the opposite. So the patient experience in our standalone unit has been so wonderful that it is not uncommon for me to have patients who either choose to wait longer to come back to the hub rather than coming up to the hospital to have their second eye, or if they've ended up on my list in the main hospital, have said to me how disappointed they are that they've had to come up here because they liked it much better in the other area. So that has been really useful for us because, of course, we found that out in the pilot, and it's been reproduced when we've now done more work in that setting. So our patients love it. And so do their family. I have to say, one of the great benefits is being able to drop them at the door. So whenever you're planning your hub, make sure you can drop your patient at the door because they really love it. The next thing is our trainees. So our trainees, I would like to think I have a holistic view to training. And one of the things that really drove this for us as a department was that Mike and I really were very conscious that our ST1s and ST2s were not getting the cases they needed and the time they needed on lists in the main hospital. So what we're really trying to do is to give the lists exactly the correct patients on them to allow the right surgeons to get what they need. So I think what we're really trying to discuss as a recovery plan and a training plan is to make sure you've got the, it's that old story, the right patient to the right person at the right time. And that's what we're not talking about great cataract trainers. We all have worked with wonderful trainers who have been able to find effortless time on an 8-patient list and train us beautifully. But what we need to change is across the board training of surgeons so that everybody gets access to what they need on the list. So our trainees are really grateful, or they say that to us, but they do say it in surveys anonymously as well. And I do think they feel supported when they need it. And one of the things, and just because I'm going to throw it in there, one of our new things is what we're calling their care package for our back to work trainees. So we're trying to develop a new care package that allows people to really personalize re-entry into training, just to get that confidence back up, because you are a surgeon for a long time and you're out of training, particularly in maternity leave, for a very short amount of time. And so I think with that kind of personalization of training and the ability to have opportunity, and that's what I mean by different lists, I think we really can think outside the box and do better.
Brilliant, thanks, Sarah. And Sunil, would you like to come in here? Are you able to, if you've got the link for speaking, is there anything from your perspective? Not sure I can see Sunil at the moment. Maybe if you come back to Sunil in a moment. And then I think the other, Carrie, I think the other area that there was a lot of chat about was commissioning, wasn't there? Should we pick that up? Declan, I don't know if you want to start having a thought about how commissioners can be supported to ensure that training takes place in the independent sector, right, with AQPs. That was I think it's lots of threads and flavours around that. And then maybe Carrie, I'll hand over to you to summarise the other questions.
Right, I think as we saw in Buckinghamshire, the demand for cataract surgery is rising at about 2% a year, which doesn't sound very much, but do add that over 10 years, compound interest is quite a lot. And this, for the first time, allows us to do some proactive business planning as opposed to planning on the basis of your waiting list, which can frequently lead to wrong decisions made in a hurry. I think the point needs to be made to commissioners that they have a responsibility to provide cataract surgery for the population under their care, and they need to look ahead. They need to engage with the trusts and with the private sector as required to really join it up and say, between us we have to deal with X thousand cataracts a year, and we do also have to make sure that the training is spread out evenly among those units. In some units it's relatively easy, as in Buckinghamshire, where the bulk of the work is done by NHS trusts. In other places, as in Leeds and Grimsby for that matter, the bulk of the cataract surgery is actually done in the private sector and probably will remain there for the foreseeable future. So in those areas, the ISs need to engage. Bear in mind, one of the key things for employers at the moment is their workforce. Unless you train your workforce in healthcare, you won't have one. We really have to attract not just the doctors, although they're leaving, but also the nurses and others. They need the opportunity to train, to stay in the workforce. We also need to bring people in to the workforce who are not in healthcare at the moment. There are a lot of people's jobs disappeared in COVID, and a lot of those individuals will be ripe and enthusiastic about taking on jobs in healthcare. So that's where I would be engaging with the commissioners. It's a question of reassuring the commissioners in some way that they can make a difference if they engage and trust clinicians and the provider trust and ISs, and also make the point to them there will be consequences if they do not commission effectively, and we mustn't be shy at the appropriate moment of saying, to address this list, where you need to put the money up front or commit to it, and also trust us because we have a plan. And clinicians then, I think, have a responsibility to actually deliver.
Thank you. Yeah, brilliant. Thank you, Declan. That's really, really helpful. And I think it's really important to say the point about ICSs in integrated care systems is that gone are the days of commissions and providers being on opposite sides of the fence. We're all in this together to do the very best we can for patients in a locality. Carrie, should I just hand over to you for a moment?
Yeah, just a couple of things. The things that were coming up was commissioning for follow-up cataracts. Well, the information that came out from both colleges indicated that that's part of the GOS. You don't need to commission for it. If you want NOD data back, you may have to pay, and they're talking about a £5 fee for that. So that does not need to be commissioned. They will sell glasses, so everybody's happy with that. It's one of these things that there's no reason. It's well within the core skills of an optometrist to refract a patient and check that their eye is healthy. That's what they do. That has been agreed by both colleges. So that's not a problem, or shouldn't be a problem. The other question that's come up a lot is cherry picking. And the differential costs and being able to do straightforward cataracts in the independent sector, but being left with the complex ones. So I just wondered if Manju, would you like to answer any of that, just as you've managed to move on to a higher volume and hopefully going to be able to pick up the more straightforward cataracts?
Yes, at Frimley, we have been doing high volume lists for a long time, maybe for 3-4 years now. But for a high volume list to be smooth, the cases should be slightly straightforward, because you cannot have difficult cases. And these days, we are finding it difficult to get straightforward cases because there are 3 independent sectors around us cherry picking all the cases. So for the Cataract Surgery Hub, we are having talks with the optom community and the commissioners. So we have a direct arrangement so they can send low complexity cases to us directly.
Yeah, I think that's the important point, is that sort of it's that conversation involving all of us, the commissioners and providers working together, so that everybody can, everybody's providing the same level of care. And I think it's really, really important to say that the high volume low complexity pathways have very senior support within HSEI. The expectation is these are what will be provided, will be commissioned, if we want to use that terminology, and all the pathways include training. So whatever we're looking at, the pathways will need to be commissioning training. And the other element of our pathways is it's very clearly risk stratified. So we have consistent risk stratification across the whole of the ICS or region, then that will promote more equity. But it's an ongoing conversation. Sorry, Carrie, back to you. I'm probably need to finish in a minute.
Things coming in about post-operative care for optometrists. I mean, the other alternative was in fact just to discharge patients, and they can do what they like, and give them a phone number if they run into difficulties. Cataract patients in general know if they've got a problem post-operatively, and they normally or quite often want to get glasses, and that was in fact the original plan. You don't really drop an agreement and just say, well, that we don't see post-operative cataracts again, that because we've got such an issue of trying to see patients who really do have sight-threatening disease. So that's the decision that was made at the time, and I don't know, Bernie was answering one of the questions because it was, as I say, it was a joint college statement that came up. So other issues that are coming through, there was a couple of things asking Manju about how you were managing to find staff to man your hub. I think people are very interested to hear about that.
Okay, so when I presented the business case, there were the provisions for 2 high volume surgeons in the business case. And at Frimley, we have a slightly bigger group of specialty doctors. And whenever any specialty doctors join, we make it a point to train them right from the beginning. And I believe cataract surgery is all about numbers. The more you do, better they become. And then we have at least 3 to 4 middle grade doctors who can do high volume lists. So they will be deployed there. And we also have a presence at Wexham, consultant presence at Wexham, which is not properly utilized. So they were also given extra sessions. And 1 day of the week is entirely sometimes provided for private work. So it was not a major issue staffing it.
What about not theatre staff and so on, as opposed to ophthalmologists, in terms of staffing the whole theatre and so on?
Theatre staffing, fortunately, there was an old Heatherwood hospital which was running general surgery theatres. They were deployed, and we are currently training them.
Yeah. Okay. Declan, would you want to maybe just a very brief final comment? Then I think we've probably, I'm not quite sure with Zoom whether we're all going to get chopped off and it'll all stop. But Declan, just a very, very brief comment, I think.
Just to say that we had an industry discussion in Wales last week, and there's a strong move there to train non-nurses to scrub for and assist cataract surgery in operating theatres. That's done in other countries, and there's a lot of movement from the Welsh government to support this as a solution. Otherwise, we just end up pinching eye nurses from orthopedics and neurology or cardiology, and it doesn't really solve anybody's problems. We need to bring other groups who are not normally in healthcare into this work, and that is one way to do it, by modifying the training programs. And I'd strongly recommend we consider that. And cataract surgery is a good place to start, because it'll make a difference, and it's a very specific training which one can learn in a specific period of time.
Thanks, Declan. We've been told we can carry on for a few more minutes till 7. Carrie, were there any other questions particularly you wanted to?
Well, I think the important thing is that there's going to be, we've been told that there's going to be an FAQ sheet pulled together on the Gov website, and the links and the slides will be made available to people attending. And I think that's probably more important in many ways than individual. I don't know how much further discussion we're likely to get unless anyone has got anything. I think we've covered the most issues that were raised, other than some of the specific ones that were covered. The training and commissioning were the two major issues that were coming up. And the independent sector, I think the only thing to say about that is it's government policy to use the independent sector, and that's sort of where we sit with that. I'm afraid. I think there's lots of people who would rather not use it, but that currently is the policy that we have to try and accommodate within the work that we're doing.
Yeah, thanks, Carrie. So maybe I'll draw things to a close just by way of final comment, and I'm very grateful to Mary for your demonstration of the Eye Care Hub. I think it's always a moment of truth whether or not you can demonstrate your new technology to a live audience. So thanks for being brave and doing that. That was fabulous. I think that just equally from a commissioning perspective within the eye healthcare improvement work, we have a commissioning work stream. I'm the clinical lead for that, so I will certainly pick up all these points because there are opportunities within that to go as people would say, to the top of the office to sort this out. So I will absolutely take all of this on board. So I think I'll close there, because I don't know about anywhere else, but in East Kent it's a nice sunny evening. Thank you everybody for joining us. We had over 100 people joining us this evening, and we'll share all the information. Please come back to us if we can provide any more. And just to say a final thank you to all our speakers, and for those in the background, Neha, Sophie and Rochelle for supporting us. Thank you, and have a lovely evening, everybody. Bye now.
Thank you.